Hi everybody, welcome to part 2 of adult life support, where we look at aspects related to advanced life support in this Dr Manny YouTube workshop. Now the learning objectives are to review artificial airways, circulatory adjuncts, look at defibrillation, look at the differential diagnosis possibilities, emergency medications, and complete it with some case studies. Now, oropharyngeal airways, you've got a number of them. They're for unresponsive, unconscious victims only. They maintain the airway, they do not protect it. So if you put it into a conscious, or attempt to put it into a conscious patient, they could gag, vomit, and aspirate, which means you haven't protected the airway. Now the procedure for an oropharyngeal airway is to measure the oropharyngeal airway from the corner of the mouth to the angle of the jaw. You insert the tip along the roof of the mouth, the hard palate, then the soft palate, turn it 180 degrees and insert it until the flange rests on the lips. The flange rests on the lips. Then you've got nasopharyngeal airways, and these are for responsive or unconscious or unresponsive victims. So they can be responsive and conscious, or they can be unresponsive and unconscious. And they do not maintain the airway, they do not protect the airway, they do, however, allow suctioning to clear the airway. Now, the insertion procedure is to measure the nasopharyngeal airway from the tip of the nose to the tragus of the ear. Then you insert the tip, well lubricated, along the upper nasal wall and rotate it gently until the flange rests on the nares. And it's typically secured. Now, circulatory adjuncts can include IV, intravenous, or IO, intraosseous access. Advanced airways, transcutaneous pacing, cardioversion, defibrillation, and medications. I'm not going to review transcutaneous pacing or cardioversion, but I'll mention it as we go through. Intraosseous access, emergency medications, resuscitation fluids, all circulatory adjuncts. Now, when we look at advanced airway adjuncts, we have laryngeal masks, tracheal tubes, suction devices, and end-tidal CO2 or capnography. And typically, laryngeal masks are devices that are simple to insert, but you do need instruction. But it does require a little bit of additional skill training, and it's not reviewed in this lecture. You've got tracheal tubes, and these do require expert consultation to insert and additional skill training, also not reviewed in this lecture. Remember, tracheal tubes are not a priority. They only become a priority unless breathing cannot be provided effectively with bag mask ventilation. You're having difficulty. Suction catheters are important as well. The large suction catheters are used for oropharyngeal suctioning, and the thinner ones are used for tracheal tubes. And look, tracheal tubes can be endotracheal tubes, or they could be tracheostomy tubes. Depends on the situation with the patient. Then you've got end-tidal colorimetric carbon dioxide detectors, and they can assess accuracy of the tube placement after tracheal tube insertion. You have defibrillators, which are a tool to provide electric shocks to the heart. you've got two main devices, AED and manual. AED is for basic life support providers. Manual defibrillators are for advanced cardiac life support providers. AED stands for automated external defibrillators, which means basically the machine is in charge and you follow instructions. Manual, you provide all the support. When we look at defibrillators, as an overview, you have what are called monophasic defibrillators, and these deliver energy in one direction through the heart. And defibrillators are devices that attempt to restore a normal heart rhythm by delivering an electrical shock. They correct dysrhythmias and arrhythmias such as SVT, supraventricular tachycardia, VT, ventricular tachycardia, or VF, ventricular fibrillation. In an adult, the recommended first dose is 360 joules, and subsequent doses are recommended at 360 joules. Then you've got biphasic defibrillators, and they deliver energy in two directions through the heart, in opposite directions. The first dose in an adult is typically recommended to be 200 joules, and subsequent doses 200, 300 to 360. And they correct dysrhythmias and arrhythmias such as SVT, VT, VF as well. If you're not familiar with these dysrhythmias, look at the Dr Manny Learn shocks. They're simple and straightforward. When we look at the defibrillation techniques, primarily there are two. Hands-on with the paddles and hands-off with the pads. The target population for defibrillation are primarily adults with heart disease that commonly convert to ventricular tachycardia VT or ventricular fibrillation VF because of their heart disease, ischemia, infarction. Essential dysrhythmias that you must be able to recognise are ventricular tachycardia and ventricular fibrillation, because you need to defibrillate these as quickly as possible. Bradycardia and asystole do not require defibrillation. The defibrillator will not have any effect on these rhythms. In actual fact, you'll put the patient, the victim, in harm's way. Now, the defibrillation procedure is as follows, and this is just an overview. But remember safety. Apply gel to the paddles or use gel pads. Verify that it's a shockable rhythm on the cardiac monitor, which makes sure that it is VT, it is VF, not bradycardia, asystole, sinus rhythm, sinus bradycardia. Select the energy setting. Now you'll have to review that. It's either for monophasic or biphasic. In monophasic, typically we start at 360 joules. In biphasic, we typically start at 200 joules. You place the paddles on the chest. You apply firm pressure. You press the charge button. And then, before you proceed, recheck to see if the rhythm is still a shockable rhythm. VT, VF. Not bradycardia, not asystole, not pulseless electrical activity. Then alert all the staff before the discharge. Tell everybody clear. Look to see that they're clear. You don't want to injure your colleagues. Then, when everybody is clear, including yourself, press both the discharge buttons simultaneously, otherwise it won't work. Then resume CPR immediately. You don't do a rhythm or a pulse check. You give 5 cycles of CPR or about 2 minutes of CPR. Then you recheck the pulse and the cardiac rhythm. Now, when we look at differential diagnosis, this is a good mnemonic to remember, especially when defibrillation isn't working. the rhythm is refractory. So you've got what is called the 7 H's and the 7 T's. The 7 H's are: consider hypovolemia, hypoxemia, hypokalemia, hyperkalemia, hypoglycemia, hypothermia, hydrogen acidosis, which really is metabolic and respiratory acidosis. Consider those, or recommend them to the team leader. That may be why the defibrillator and the defibrillation isn't working. Then you've got the 7 T's: trauma, tamponade, tension pneumothorax, thrombosis, could be STEMI, pulmonary embolism, could be toxins, overdose of tablets, it could be cardiac transplant. Now, resuscitation medications are as follows. Oxygen is probably the most important resuscitation medication with effective CPR. It improves tissue oxygenation when you provide an effective circulation with CPR. The indications are respiratory insufficiency, distress, saturations of less than 94%, chest pain, angina, cardiopulmonary arrest. The dose is always the maximum, 15 litres per minute, which should provide 100% oxygen. Then you've got epinephrine. Epinephrine is another important evidence-supported resuscitation medication, and the action is as a sympathomimetic because it stimulates alpha, beta-1 and beta-2 receptors. The indications are for symptomatic bradycardia, pulseless ventricular tachycardia, ventricular fibrillation, asystole and pulsus electrical activity. The dose is typically 1 milligram, which can be repeated every 3 to 5 minutes. There's no maximum cumulative dose. Then you've got vasopressin, which is also supported in the literature. This acts on V1A receptors and causes peripheral vasoconstriction. The indications are VT, VF, pulsus electrical activity, and asystole. And it can be used as an alternative to epinephrine in the first or second dose. The dose is typically 40 units intravenously, but only one dose is given or recommended. Then resume with epinephrine every 3 to 5 minutes if required. Amiodarone is an effective broad-spectrum antidysrhythmic. Its action is class 1, 2, 3, 4 as an antiarrhythmic. Have a look at the pharmacology lectures that I provide in the Dr Manny Learn shops if you choose to. All explained very, very clearly. The indications for this medication are defibrillation, refractory, VT or VF. It's not responding to defibrillation. The first dose is 300 milligrams, diluted in normal saline 20 mils, and the second dose, if required, is 150 milligram as a bolus. Maximum dose should not exceed 2.2 grams in a 24-hour period. Atropine is a medication for symptomatic bradycardia and second-degree AV block. However, it's no longer recommended by the American Heart Association for asystole or pulsus electrical activity. The action is as a parasympathetic muscarinic blocker. It increases heart rate and causes bronchodilation. The indications are for symptomatic bradycardias and second-degree AV block, which I already said. The dose is typically 0.5 to 1 milligram every 3 to 5 minutes, with a minimum dose of 0.5 milligrams and a maximum dose of 3 milligrams. Calcium chloride. This is a positive inotrope. It increases contractility of the myocardium, and it's an essential mineral and electrolyte. And this is indicated for hypocalcemia, hyperkalemia, calcium channel blocker overdose, magnesium toxicity, beta blocker overdose. The dose in an adult is recommended at 1 gram, and there is no maximum dose. It can be repeated as required. Magnesium sulfate is classed as an antiarrhythmic. It has a weak class 1, 3 and 4 effect, and it is an essential electrolyte. And it's indicated for cardiac dysrhythmias, especially for polymorphic ventricular tachycardia, torsades de pointe. The dose is typically 1 to 2 grams, with a maximum dose of 2 grams. Sodium bicarbonate, although not recommended often, increases plasma bicarb. It elevates your blood pH, and it's indicated for hyperkalemia or prolonged cardiopulmonary arrest with a profound metabolic acidosis. The dose is typically 1 milliequivalent per kg of an 8.4% concentration, and subsequent doses can be given 10 minutely at a half dose, 0.5 milliequivalents per kg. Now let's review. Can you name the resuscitation adjunct recommended for unresponsive victims to maintain the airway? Oropharyngeal airways. Correct. Can you name the resuscitation adjunct recommended for responsive victims to allow suctioning of the airway? Nasopharyngeal airways. Correct. Name the defibrillation device which can be employed by BLS providers if credentialed and if required. An AED is the device. Manual is only for ACLS providers. Can you state the cardiac dysrhythmias which require defibrillation? Ventricular tachycardia, ventricular fibrillation. These need to be defibrillated or stopped. State the resuscitation medication which is in all probability considered the most important if you provide effective CPR. Oxygen. Oxygen is probably the most important resuscitation medication with effective CPR. Let's conclude this Learn Shop with a case study. 35-year-old male complaining of angina pectoris, chest discomfort and shortness of breath. He was admitted to the emergency department, and the current situation is code blue. The patient is unresponsive. The monitor ECG shows this. What's the cardiac rhythm, and how do you treat it? This you must know. The cardiac rhythm is monomorphic ventricular tachycardia. You commence BLS and you have activated the emergency medical response. The code blue was already called. You defibrillate with 200 joules biphasic or 360 joules monophasic as the first shock. You give IV epinephrine 1 milligram every 3 to 5 minutes, or vasopressin if you have it available. IV amiodarone 300 milligrams can be given if refractory, and you can repeat 2 and 3, defibrillate and epinephrine in sequence. Okay, thanks. This ends the adult Learn Shops for life support. If you found these of any benefit to you or of any interest, please recommend them to your colleagues. Subscribe if you choose to. And look, have a look at the Pediatric Life Support Part 1 and 2 on YouTube. See you soon.